Hello friends, I am Dr. Abhinav Prakash from Model Town, New Delhi, India. Today I am going to show you the surgical video of phaco emulsification done by me in a high myopic patient of -10 diopter. Also he had history of vitrectomy for rhegmatogenous retinal RD, retinal detachment 2 years back for tearing retina. Just let's discuss briefly why such surgeries are challenging. Intraoperatively, deep anterior chamber and liquefied or no vitreous, hence no support to the posterior capsule, and chances of iris lens diaphragm retropulsion syndrome because of weak zonules. When the ultrasonic tip is introduced into the eye, highly myopic eye, and inflow is activated, the anterior chamber deepens and the lens iris diaphragm is displaced posteriorly. So the iris become more concave and the pupil dilates from the weight of the water column above the eyes. Such situation can be handled by lowering the bottle height. So we are injecting the viscoelastic in anterior chamber before starting the capsular axis. In such cases, care should be taken to perform the rexes very gently to minimize the stress on the zonules. So this is 2.2 millimeter main port made with the help of 2.2 millimeter keratome. So we are going to initiate the capsular axis with the help of capsular axis forceps. Care should be taken that capsular axis should be very gentle to minimize the stress on zonules. So it should be done preferably with the rexis forceps. Any weakness of zonules should be noted and taken seriously. As you can see, the AC anterior chamber is very deep. During capsular axis, anterior capsule seems to be more posterior, so difficulty in access to do the rexes, as the structures seems to be more deeper than the usual. Rexes should be of moderate size. So this is hydrodissection with the balanced salt solution. And hydrodissection should be very gentle to avoid stress on the weak zonules. The nucleus should be rotated, which is a very important step before starting the phaco emulsification. So here I am going to perform the direct chop or vertical chop technique. The tip is embedded into the core of the nucleus. Here I am rotating the nucleus again and again to get my first chop. Stabilize the nucleus by burying the phaco tip into the nucleus, and with the help of Sinski hook we can chop the nucleus into two parts. So here I got my first chop. During phaco emulsification, the nucleus should be brought into the AC so that it's easy to chop it. As the AC is very deep, it is difficult to chop it in the bag. Another advantage of bringing the nucleus more anteriorly is as the AC anterior chamber depth is more, we have plenty of space to perform phaco emulsification away from the endothelium, so that the damage to the endothelium of cornea can be minimized. So you can do it in the pupillary plane. In such cases, posterior capsule is highly fluctuating. Posterior capsule is not fixed, so keep the bottle height higher than the usual, so that the anterior chamber is formed all the time. And be very careful that the tip of the phaco tip of the phaco probe and the dialer, the Sensky hook, should always remain in the safe position. So we have emulsified the nucleus, and now we have to remove the cortical matter. The cortical cleanup is done with the help of coaxial irrigation and aspiration. You can also perform bimanual, whichever is more convenient to the surgeon. Now irrigation and cortical cleanup is done. Now the anterior chamber and the bag is filled with the viscoelastic. Here I have performed the limbal relaxing incision to neutralize the astigmatism of opposite limbus. Here I am loading a single piece intraocular lens into the cartridge, and it is injected with the help of injector. First the leading haptic into the bag, then the trailing haptic is dialed gently, very gently into the bag. More viscoelastic is injected, bag is inflated. Never try to do anything forcefully in such cases. Everything should be very smoothly and gently done without any force. Now the viscoelastic removal is done from the bag. See how the capsular axis margin is covering the optic margins from all 360 degree, all the sides. Visco is removed behind the eye. Irrigation and aspiration. It is very important to remove the viscoelastic behind the IOL, and all the lens cortical fibers are removed. So I can still see few fibers behind the IOL which are not coming out with the help of irrigation aspiration. So I would use this hydration cannula to remove those cortical fibers. See, they are coming out, and each and every step should be done very meticulously, because the posterior capsule is very free and mobile. It has no support, there is no vitreous, so posterior capsule can come anteriorly in any step. It can hit your cannula, it can hit your Sensky hook, it can hit your phaco tip. So be very careful and keep your anterior chamber inflated all the time with viscoelastic. So this is extended depth of focus Abhinav lens I am using, which has very good results post-operatively in high myopic patients. So this is Abhinav lens. Side ports and main ports are hydrated and checked for any leak. The anterior chamber is sealed. Intracameral moxifloxacin is injected, and we got very good results. Next day, patient was emmetropic and very satisfied. Side ports are checked for any leak. Thanks for watching.